Oh, yes, it's visible.
Good.
Yeah. My greetings to you, Dr. Anna. I'm Dr. Usha. I'm the coordinator for Manipal Health Literacy Unit. And we have our wonderful students who are actually coordinating all the webinars that include Abhinav as well as Pallavi. So, yeah, over to you, Pallavi.
Thank you. We'll begin with the session now. So, perfect afternoon to everybody present here. I am Pallavi Kamath, a first-year MHLU student at Prasanna School of Public Health, MAHE Manipal. It is my honor to welcome all the participants to the 15th webinar organized by the Manipal Health Literacy Unit, known as MHLU, organizing a free webinar on health literacy for healthcare providers, researchers, policymakers, industry, academia, and the public. Before we introduce the speaker for today, I would like to request a few things from all the participants. First, please take a moment to mute your cell phones and microphones. Feel free to post any questions in the chat box during the session. We will address a selection of questions considering the time constraints. Thank you. So in today's webinar, we will hear experts' insight on health insurance literacy across borders, Switzerland and international perspectives. So ladies and gentlemen, please allow me to introduce our speaker for today. And Dr. Anna, please forgive me if I pronounce your name wrong. We have with us Dr. Anna Cecilia Quiroga Gutierrez. Dr. Anna is a researcher specializing in health economics and public health. Her doctoral research focused on health insurance literacy. Based in Switzerland, her work centers on empowering individuals to optimize their health insurance choices through personalized information interventions that makes complex information accessible and tailored to individual needs. Dr. Anna's research sheds light on the nuances of Swiss health insurance system, emphasizing the importance of informed decision making to help people select insurance options that best meet their unique needs. Please join me in welcoming Dr. Anna. Over to you, ma'am.
Thank you. Thank you for that very nice introduction. I'm very happy to be here and excited to also have a discussion with all of you. And before I start, I just wanted to ask, I was told 30, 45 minutes, but does that include time for questions, or should I leave time within that time frame for questions or discussion?
You can have the time for the presentation and we can carry forward the question and answer after that. Since we have 1 hour with us, we can do that way.
Perfect. Then I will go through everything with time and try to explain everything clearly. So thank you again. I'm very happy to be here. So yes, like it was very kindly introduced, I will be talking about health insurance literacy and some of the findings that we have seen across the world, or more than anything in the US, because that's where most of the research has taken place, as well as some other places, and Switzerland, of course. So just to give you an idea of what I'm going to be covering today, I'm going to start with a very brief overview or kind of outline of different systems or classifications for health insurance or health financing that there are. Then also how health insurance decision-making takes place, or some important aspects of it, and health insurance literacy itself. Some global perspectives or findings that have been taking place around the topic, and then focusing on my own research in Switzerland. So first I'll start with some overview of different classifications of health insurance models or ways of financing health. There are a lot of ways of classifying this that take into account different aspects. And the most classical one of them involves these 3 models. So the beverage model, which is mostly financed through taxes by the government, and the service providers tend to be public. A good example of this is the NHS in the UK, or like the classical example. Then there's also the Bismarck model. In this case, insurance or coverage is mostly provided through insurers and is financed through payroll contributions. And the providers of the services are private, but they are heavily regulated by the government. A good example of this one is Germany, or like the classical one. And then there's also private insurance model, which is financed by the insurance premiums that people pay directly to the insurance companies. In this case, the providers are also private, and a good example of this is, of course, the US. Now, there is a little problem with this classification. It doesn't really fit all of the systems that we see nowadays in a lot of different countries, because most of the times countries incorporate different elements of these models or have a combination of them. And there have also been different developments like managed competition, which I will also be talking about later to make that a bit clearer. So for the purposes of this presentation, I would like you to think of how health is financed or covered in this kind of simplified way. So first, we have systems that have universal coverage, that one single primary insurer, like the UK, right? So the government basically covers everything. Then we have also systems with universal coverage, or there's 3 in total that have universal coverage. In this case, with multiple private primary insurers. So in this case, there's a lot of different insurance coverage companies, but the one you cannot choose which one you go to, and you're assigned to it based on your employment, where you live, and other characteristics. And a good example of this is Japan, for example. Then there's also a system with universal coverage, where there's different insurances or insurance companies that compete to get people to insure. So an example of this is the case of Switzerland, where we have managed competition. And then there's also systems that do not have universal coverage. And one example of this is the US, where not everyone benefits from coverage from Medicare or employer provider insurance, etc. And then, of course, there's other modalities like community-based health insurance in developing countries. So because a lot of my research or health insurance literacy focuses on the choice that people have regarding health insurance, I'm going to be focusing, for the purpose of this presentation, mostly in these 2 last categories. So those that have universal coverage systems, but where people have a choice of insurance, and systems that do not have universal coverage and people have to look for and select their coverage. I would also like to go through some of the basic concepts of what makes up a health insurance, right? All of these different payments that people have to make when they have health insurance. So the first one is the premium, or the franchise, as it's called here. This is the amount that people pay every month or in a total year to have access to this health insurance, right? So that's called the premium. Then we have the deductible. This is the amount that if anything happens to you or if you need care, then you need to pay this amount before the health insurance starts covering your expenses. Then we also have a co-payment, the third one here that you see in the middle. This is a fixed fee that people have to pay every time they go, for example, for a doctor consultation or they receive a service. Then we also have co-insurance. I know it's a lot of terms. We also have co-insurance. This one is basically once you reach your deductible, instead of keep on paying your full cost of everything, you pay a percentage of the costs. That's co-insurance. And then this is a word that I will probably be using quite a bit during the presentation, the out-of-pocket maximum. This is basically all of these other components or elements combined. So the premium, the deductible, co-payment, co-insurance, everything that people have to pay out of their pocket together. And the maximum out of that, for example, is when insurers have a cap that says, okay, if you're going to be paying premium, deductible, co-payment, this is the maximum that you as a person are liable to pay in a way. So now that I've covered some basics of some of the components or classifications of health insurance, I'm going to start talking about health insurance decision making and health insurance literacy. So Health insurance, as you can imagine, is a decision that is very difficult to make, and that it also depends a lot on the context, and it can have different types of consequences. For individuals, it helps to protect their finances, of course, because it puts a limit on the amount of money that they have to pay. So if something bad happens to you or if people get sick, it protects them from having this catastrophic healthcare expenditures. And then, of course, it protects your health because you get this access to health to take care of it, right? And then there's also consequences for society, especially in places where there is choice and people can select their providers. Then this competition of having people choose stimulates competition among providers, innovation, and quality improvement. So it is very important to drive quality too. And there are different aspects or things that are kind of needed for people to make a choice or take a decision that is well informed. For example, you need to be able to first accurately evaluate your own needs, know what your health status is and how likely you are to need certain services. Then you're also required to understand health insurance because, of course, if you have a lot of options and you don't know what these terms mean, it can be very difficult to make a decision. And then, of course, as the last one, discriminate between choices, right? If we are not able to tell apples from oranges, then it's very difficult to know what we want. But there are some challenges. This is not always easy, and there's a lot of research showing this. First, we have choice overload. This is a result of having a very complex choice environment or setting where there's a lot of different options. Usually the more options you have, the more confused you are and the more difficult it is to make a choice. I'm sure you have all related to this. If you go to a restaurant or somewhere to eat and there's two options, it's way easier to decide what you want when you have a menu of 30 pages, right? There's also a lot of information out there. This varies, of course, from setting to setting, but sometimes the more information you get, the more you have to process things and think about it, and the more complex it becomes. And this is particularly true when we look for information online. There's increasingly number of tools or websites that try to offer information, and while some of them are well-intentioned, this can also be confusing or add to the problem. And then there's also information frictions. So there's a lot of things that we may not be so sure about. For example, there's uncertainty about our own health and how much we're going to need to be spending on health on a given year. Then the product is also very complex. Health insurance is one of the most complex products that people pay for all the time. And there's also mental gaps. And this refers basically to when people have information or there is information available, but we cannot use it because we don't understand the terms or it's too complex or any other reason. So all of these are things that come into play and that can make this decision a bit more difficult. So an important concept that has developed in relatively recently is health insurance literacy, and of course, the topic of this webinar. So this is a relatively young term. It was given its kind of official definition around 2014, and it is the degree to which individuals have the knowledge, the ability, and confidence to find and evaluate information about health plans or health insurance, select the best plan for themselves or their families, and then also use it once they have it, right? So it's not just about knowing about it, it's being able to find information, use it, etc. And there is this, there are basically two different health insurance conceptual models. This is the one by Weiss et al., and it basically describes the different components that make up health insurance literacy. And these ones are knowledge, so understanding health insurance basically. Information seeking, this refers to being able to find the information regarding health insurance when you need it. Document literacy, like being able to fill out the forms and request the documents that you need, and cognitive skills. This relates more to being able to calculate costs or know more or less how much you're spending, things like that. And all of this has an underlying domain or component that is self-efficacy. And this is the confidence that people have to make these tasks. Because people can have the knowledge or be able to find information, but if they don't feel confident enough to make the decision, then that is still a problem. This is the second conceptual model that has been developed. This one is by McCormack et al. And it basically shows the different aspects that are associated or can influence health insurance literacy, and involves individual aspects like age, education, race, culture, to other aspects like your health status, whether you have financial literacy, numeracy, and some others. And then, of course, we can also see some consequences of it, right? So we have patient-provider communication. If you don't understand a lot of these terms, then you may have issues communicating with your providers. And this can also result in health outcomes, right? Which can be influenced directly or indirectly. So why is this important? Well, there is already, even though it's a relatively young term, there's already some research on the topic. And people have found that people that have low health insurance literacy, that have issues understanding insurance or are not confident enough or whatever it is, that they have limited health insurance literacy, they are more likely to not go get care when they need it or delay it, which of course is bad for your own health. They're also more likely to have medical debts, which is bad for your pocket and your health as well, right? And then they are also more likely to rely on heuristics or mental shortcuts to select health insurance. And by heuristics, I mean things like, for example, just choose the insurance that comes first to mind because you have been looking at advertisement lately, or, you know, this kind of mental shortcuts that we use to make decisions to make them easier. But this can have negative consequences as well. Now, we kind of have an idea of what health insurance literacy is, and I'll show you now some of the results that have been gathered through research, not only in Switzerland and the US, but more or less what we have gathered so far overall. So as part of my doctoral research, I did a systematic literature review, and I wanted to see how much the concept of health insurance literacy had developed and how it was measured, because we were also interested in measuring it here in Switzerland because we didn't really have a measure or an idea of how much people know about health insurance. So I did a search on different databases and found different publications trying to measure health insurance literacy using quantitative methods and mixed methods. And as you can see in this map, the dark blue is the US. Most of the publications, about 80% of them, came only from the US. And then you have a few countries here or there that had a little bit of research on the topic. A lot of them only had one or just a handful of publications of health insurance literacy. And then another thing that I found was that, yes, there was some research at the beginning, like starting in the 80s, mostly on whether people understood or comprehended health insurance, but not, of course, health insurance literacy per se as a concept because it hadn't been defined yet. So I included all of these different concepts like health insurance understanding, comprehension, etc. And these were the number of publications per year. And as you can see, I mean, people have been looking at this for a while, not as health insurance literacy as it is now, but something similar at least. And the research on the topic has increased quite a bit since mostly 2015. And a big reason for this was the expansion of Medicare and the Affordability Care Act in the US, which kind of pushed a lot of research on whether people understood health insurance or not because it was important for them to take it. So these were some of the results. We had a lot of publications, as you can see, over 5,000. So that was a lot of work and reading. Out of this, we found 123 original measures trying to measure health insurance literacy in one way or another. The problem was that a lot of them were just one item questions like, do you understand health insurance literacy? And that was it. Out of this, 19 tested for psychometric and measurement properties. So basically, they actually tested or proved that they were really measuring what they were trying to measure, health insurance literacy as a concept. And then 4 of them assessed all of the domains that I showed you earlier in the 4-domain model for health insurance literacy. And only 1 of them was developed and used in the context of private health insurance. Most of the other ones, like at least the 19 measures that were tested for psychometric properties, most of them were developed in the context of Medicare, where you don't have the same amount of or degree of choice as you have in private health insurance. So at least for the context of Switzerland, we found that this measure, the last one we found on private health insurance, the health insurance literacy measure, was potentially the best thing to adapt for Switzerland. And so a colleague of mine also adapted it and she validated it here in Switzerland, and some of the results have already been published as well. So some of the takeaways from this study were that the expansion of Medicare has played a very important role in developing health insurance literacy as a concept and research as well. And that health insurance literacy, of course, is context specific. I mean, we can see that in the heterogeneity of different measures that have been used and the type of questions that are used in different contexts. And there is also a lack of standardization. This is starting to change because some of the same measures are being used over and over again. But a few years ago, everyone was trying to come up with their own measure. So it was really hard to compare across countries or even similar settings. Now, some other findings in relation to health insurance literacy. It has been found that there is a positive association between health literacy and health insurance literacy. It is also associated with mental health literacy and internalized stigma. This could potentially be an issue for people that have mental health issues, because if they have low health insurance literacy and they have this type of issues that they need to take care of, they might be less likely to access the care that they need. Then there's also certain groups that are more likely to be affected or suffer consequences of low health insurance literacy. And this, of course, includes some minorities and younger individuals, African Americans, Hispanics, Spanish speaker, or people with lower education levels. And there's also some research showing that at least among groups of cancer patients, people that have low health insurance literacy, they are more likely to have financial issues, problems paying their debts. And then, of course, in the long term, this can affect their care. There is also some research and evidence that is starting to emerge from a very nice group in the Netherlands. And they have seen how also, the system is in some way similar to the one in Switzerland. And they have seen that people with low health insurance literacy find it difficult to choose health insurance, or they are more likely to think that it's not interesting, boring, or less important, even though they know they have to get it. So now back to some of my own research. I will go through some of the things that we have found here. And first, I would like to give you a bit of context, because I think Switzerland has somehow of a special system. There are others that are similar, but I just want to give you a little bit of background. So here we have a system that is based on managed competition. And what this means in just a few words is that people are obliged to get health insurance. So it's a mandatory health insurance, but it is offered through private health insurance companies. And the prices and what is offered is regulated by the Federal Office of Public Health. People can change their insurance every year, and there are different levels of deductibles that people can choose from. And of course, how much they pay for their premium, which is this payment that people pay every month or year, that is fixed, varies depending on the level of deductible that you choose. And there are also alternative models that can potentially reduce your premiums, like selecting telemedicine models or family doctor model. So these options can reduce your costs. And even though people are, you would expect them to be relatively familiar with the system because they can change it every year and they have to have it, right? 20% of individuals do not know the details of their health insurance plan. 30% have difficulties finding information about health insurance that they need. And about 40%, so almost half, I mean, this is quite high, find it difficult to select the health insurance. So I mentioned before why health insurance literacy is important in general. And in the particular case of Switzerland, this is important because costs have been increasing rapidly in the last few years. So this means that people that have a certain amount of money for expenses each month, as years progress lately, they have less resources because they have to spend way more on health insurance. So their disposable income has been affected. And of course, as I mentioned before, health insurance literacy affects access to care potentially because of costs, right? And this is also the case in Switzerland. The amount of people that do not go to the doctor or don't get medicines when they need them has significantly increased in the last years. And this could potentially be a reason for it. There's also several national strategies that are aiming towards empowering people to make decisions that are better informed and in relation to their health or that can affect their health. And because of this rising costs and trying to keep up a high quality standard, which Switzerland has, then they're trying to also adopt new models and solutions, but it can be very hard for people to actually choose these innovative options if they have issues understanding them. So it becomes important for people to become more aware and make informed decisions. So as part of my project as well, which it was part of the Swiss Learning Health System, this is basically an initiative that has the aim of looking at the decisions that are important for the health system here, conducting research, collecting data, and then informing decision-making for health policy based on this evidence. So because we thought this was a relevant topic, we also wrote a policy brief on how to improve health insurance decision-making in Switzerland. And we identified some issues, mostly that there's not a lot of information on the different levels of health insurance literacy that the population has and its distribution, or who has high or low health insurance literacy, basically. There's also not a lot of information on what the potential consequences of these different levels could be, or what we could even do about it, right? How do we help people that have low levels of health insurance literacy or need help making decisions? So there's not a lot of options because we don't know how effective they could be. And based on this, we made some recommendations. So the first one was to further data collection. So there's several national surveys that take place. So we thought it could help to integrate at least a few questions to get an idea of the levels of health insurance literacy in the country, to be able to identify vulnerable groups and how much they actually need help. And then the provision of decision support tools and information to help them make decisions, and the development and the strengthening of health insurance literacy through education. Because there's also countries, for example, Finland has a very strong focus on health literacy already in schools, and they put a lot of effort in strengthening these skills because they know that in general, not only for health insurance, but for the whole health system, it is very important for people to learn how to navigate it since they're young. So as another part of my project, we wanted to find ways in which we could help people make better choices, regardless of their health insurance literacy levels. And of course, even better, we could help those that have low health insurance literacy, because they are the ones that need the most help or have more issues or problems when it comes to making these decisions. So to do this, we ran an experiment. This was a computer laboratory experiment that we ran here in 2 universities in Switzerland, in which we provided participants different types of information to help them make these decisions. So just to give you a very brief description of the experiment, because I could speak for quite a while about it. So happy to answer any questions. This was a randomized computer laboratory experiment. There were different rounds. So it was basically like a computer game where people go through different rounds. So each round was a period or like the equivalent of a year. So they could choose their health insurance for the next round. And people were compensated. So they could accumulate points during the experiment. And based on how many points they accumulated, they would get paid. So of course, you would assume that people wanted to accumulate as many points as possible because then they would get paid more, right? So people could earn points through answering trivia questions, which also served as a distraction, and also by a fixed income. So each round they received a certain amount of points. They could also lose points because they had to choose their health insurance for each period, so they had to pay the premium. There were different events that could take place in each round, and there were 3 different types of events, and each of them had a different cost, let's say. And 2 of them lasted only 1 round, and 1 event affected 2 consecutive rounds. So they could potentially also pay deductibles. And they were given the probability of each event potentially taking place. So in theory, they should be able to, or they would be able to calculate what their expected costs were based on the probability of these events taking place and the cost of each. And based on this, they had all of the information they needed to make the best choice in terms of health insurance to reduce their costs so that they could accumulate the most amount of points and get paid the most at the end of the experiment. But that's not how it went, of course. So we had different treatments. We had 1 control group that received no information at all during the whole experiment. Then we had a general information treatment. This was provided to all 3 treatments. Treatment 1, 2, 3, and 4. Sorry, 4 treatments. Then there was also optional personalized graphical information that was offered to treatment 2. So they had a general graph, and then they could choose to be let known exactly what their costs were, expected to be at least. And then there was also personalized numerical information, which presented the same type of information, but using a table with numbers. And there was 1 treatment, treatment 4, that presented general information. And then instead of giving them the option of accessing only 1 type of personalized information, they could choose what type of information to access. So they had 2 buttons instead of just 1. And just to give you an idea of what this looked like, this is the general information. And this is already relatively complex to look at and understand. which is why we thought personalized information would help more. So in this graph, let me see if I can do this. Yes. So in this axis here, well, let's start here. In this axis here, this is health expenses. So basically, based on the probabilities of the events that we gave them and the cost of each, they could calculate where on this axis they were on their health expected costs for that period. And then based on this, for example, if your costs are 1,500, you go up here, then you can see this green line. This is the insurance with the 2,500 deductible level. These are the different deductibles that are available. And so this one would be the cheapest plan for you. And you would be, your expected total costs for the period would be around 4,500, something like that. So this is already relatively complex, but this was our general information treatment. This is a personalized information treatment. So the difference with this is the same graph, but we told people, okay, these here are your expected costs. So of course, it's way easier to identify here already, which is the cheapest plan. So again, in this case, it's the green line. So the plan with the deductible of 2,500 francs or points in this case for the experiment. And the personalized numerical information looked like this. So it was basically a table telling them how much they would save with each plan based on the plan that they had at the moment. Our sample consisted basically of 433 participants in 2 different laboratories in the German-speaking part of Switzerland. And because we recruited through university pools, our sample was relatively young, also more educated than the average population. About half of them were Swiss, and they all, on average, had a relatively good health status as well. So these are some of our main results. So first of all, people that had 2 options to access information, personalized information, to help them make these decisions were less likely to access it. And I thought this was a very significant result because the only difference here was you have 1 button to access this information or you have 2 buttons. So already just adding 1 button decreases the likelihood of people accessing the information they need. Then also participants that chose in or selected to view this information reduce their costs. And not only that, but they also spend less time selecting their health insurance, which meant that they also had more time to answer trivia questions and earn even extra money. So this reduced their switching costs in a way. And this is basically a graph of some of our results. So you can see in the right side graph the different treatments that we had. And this line here is the personalized graphical information. So in this case, the difference between the numerical information and graphical information was not statistically significant, but we can see that there's an indication that is slightly stronger. One of the issues, of course, that we saw is, as you can see, there is an effect. So people reduce their costs, which is great, but you can see that this afterwards go up. So something happens that people switch, even though their risk profile didn't change. So their expected costs stayed the same throughout the experiment. The effect was only temporary. So that also tells us something about how it is important to constantly give people this information when they need it, when they're making these decisions. Then we ran also another analysis, or I conducted another study using the same data from the experiment to see what people actually, who benefited the most from this information, right? Because what we are interested in is making sure that we help the people that are struggling the most to make these decisions, or the most vulnerable groups, right? So here again, we see that the lower this, so each dot is basically a participant, and in a given round, in round 3 of the experiment, after the information was provided, or at the time that the information was provided and they could access it, the lower they are on this graph, the less likely they were to access the information. And so we can see that people that are less likely to answer the information when they have 2 options are those that answer less trivia questions, had lower health insurance literacy, that's one of the domains for it, and that had accumulated less points or had less money in the experiment. These blue points were also people that experienced a moderately expensive health event. So you can see that there was some kind of shock that also affected their decision-making or access to information at that point. And then for the impact of of personalized information, again, with this heterogeneity analysis, which was done using machine learning techniques, we used causal forests. We can see that people that benefited the most, again, those that are in the lower parts of the graph, so basically here, 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 these people reduced their costs more when receiving personalized information compared to the others. And those, again, were people that had low balance or accumulated less money or points, or were poorer in the experiment, in a way, and those that had low health insurance literacy. So that's what we wanted to find, basically. Giving this information to people that have issues understanding health insurance can help them a lot. So some of the main takeaways is that more is not always better, because we saw that providing more options decreases the likelihood of accessing information. So it's not very beneficial. And personalized information helped the most, especially for the most vulnerable groups. And also, I forgot to mention in this heterogeneity analysis, there we did find a significant difference between graphical and numerical information. So we can see that these vulnerable groups benefit the most from visuals or information that is simplified in a way and easier to apply to their decisions. And just to wrap up, just some take-home messages. First of all, health insurance literacy is very context-specific, so it's very hard to just choose one measure universally and apply it, because of course, systems and contexts vary so much from one place to the other. And there are some existing conceptual models and measures that can offer some good foundation, but depending on the context, of course, they need to be adapted. So it is important to see which one would fit best according to your setting. Then personalized information improves health insurance decision-making. So this can be a very valuable tool, particularly for those that are most vulnerable, right? The problem is that the most vulnerable people are also the ones that are less likely to access this information. And so it's important to focus on finding ways to reaching them that are effective. And then in general, as in a lot of things in life, it is important to aim for simplicity and quality over quantity. So yes, there's a lot of different tools and websites that can potentially have good intentions, but we need to be a bit smart in terms of how we present these things. So it's better to have a few options that are better presented and may cater to these vulnerable groups better than just throwing a bunch of information at everyone or options, right? And as a result, it is important to simplify these environments in which people make choices. And of course, presenting information is only one way of doing this. There's a lot of other strategies that can be used, but this is at least what we focused on during this project. And yeah, thank you. I would like to just thank my PhD supervisor, which was a great support, the Faculty of Health Sciences and Medicine at the University of Lucerne, and the Swiss learning health systems. And I'm happy to start discussing with you.
Yes. Thank you so much, ma'am, for the session. And now we have some time for question and answers. So if anybody has any questions, please do put them in the chat box and we'll read it out. We do have a question. Given the rapid advancement of digital tools, how do you envision technology shaping the future of health insurance literacy?
That's a very good question. Well, I think there's a lot of things that can be done. Again, we have to be careful because this can lead to the same choice overload issue, right? That we have a lot of resources with a lot of information. This can be counterproductive. But there has been some research on how to use some tools, and there's also companies also here in Switzerland that have started implementing digital tools or ways of helping people through websites. For example, in the US, there's at least in terms of digital tools, there's websites where you can go and answer a few questions so they get an idea of your health status, your income, and other different aspects. And then based on that, they give advice. There's also some websites that have kind of nudges in a way that, for example, have a little button of, if every year you spend less than a certain amount, then most likely this type of plans are best for you. So there's a lot of tools that can be developed. I think this also depends on the kind of system that you have in place, right? If competition among providers is important, then they're driven to implement these kinds of solutions because that's good for their customers. But in systems where there's not so much competition, then there might not be as many incentives to also implement them. I don't know if that answers your question.
Yes, ma'am.
Perfect.
So thank you. Thank you for the answer. We have another two more questions. So one is, what role do policymakers play in improving health insurance literacy? And how does this vary between Switzerland and other countries?
Yeah, that's another very good question too. Yes, policymakers definitely play an important role. And a lot of it, or the role that they play, I think, depends a lot on the context as well. I can speak for the case of Switzerland. For example, the national strategies are focused a lot on personal empowerment. So there's a lot of this kind of perspective of this is people's responsibility. So we have to have ways to support them and empower them into making these decisions. But in the end, is their role, like the individual role. So I think, at least in these cases, when the individual is responsible for these things, then at least there should be ways of empowering them and informing them to make these decisions, potentially through education, provision of information, like I mentioned before. And then if that is, of course, settings in which policymakers or government bodies are more involved in other ways, right? Especially when they are the providers or types of choices are different, then they can potentially take a more proactive role rather than just educating and providing information. Yeah, but I think it varies a lot from context to context, just the way that health insurance literacy does.
Definitely. Yes. Thank you, ma'am. We have one more question. What are the risks of misinformation online, and how can individuals be taught to identify credible health resources?
Yeah, that's also tricky. I think, especially with upcoming technologies, right, like large language models that can make a lot of things that are potentially not true or fully true sound very well and easy to believe. So yeah, the problem of having more information online is that a lot of it cannot be good, right? Or potentially dangerous or misleading. So yes, there is definitely a risk. And
the
a big
follow-up.
part of, yes, the one thing is another type of literacy is information literacy, which I think is also very important. And this should be a part of education, in my own view, to help people be critical about where they get their information from and to also question it. I think that's a very big part of it, and something that is potentially going to gain a lot of traction now that there's increasing amounts of information and sources online.
Yes.
Um,
We have two more questions, ma'am. One,
yeah.
personalized information, as you mentioned, is the most effective. So, what kind of personalization are we referring to? And are we tailoring the insurance itself to the medical needs of the patients, or are we tailoring the insurance information to suit the audience? And are there any companies offering that are offering insurances?
Yeah. So the personalized information that we tested was in reference to costs. So basically, in short words, it was based on your health profile. We could expect you to spend more or less this amount of money. And based on that, this is the best choice for you. So it's very targeted to the individual based on their own costs, right? But this could also be based on other types of information. This is just one example. And this is basically in relation to the health status and their medical needs. And there's, for example, other ways in which this has been implemented. In the US, for example, there are now navigators. These are basically people that you can call and have a conversation with them, and then they can guide you in making these decisions. So that is really personalized. Of course, not every context has the capacity to implement these kinds of models. And in those cases, I think just providing simple information, you have to simplify it as much as possible because this is very complex information. So the only way that people are going to use it is if you make it easy to use and understand. So of course, the more targeted it is, the better, but this can sometimes be tricky and can take up some resources. So implementation can vary and of course should be adjusted to your own resources.
Yes, definitely.
I saw
I think
there
we
was
have time
another, sorry,
for one
yeah.
last question. Yes. What do you think are the most pressing gaps in current health literacy policies that we need to address right away?
Oh, wow. Well, I mean, if it comes to health literacy in general, that I think that's quite broad. Health literacy includes a lot of different aspects that affect our health. And I think this is something that should be addressed from childhood and throughout the lifetime, right? I mean, we keep on learning not only as individuals, but also as a system, right? And we can take the example of the COVID pandemic. Nobody knew anything at the beginning, right? And so sometimes we have to learn as we go. And I think it's important to develop these skills of having some basic health literacy skills, even from when you're little, and just learn how to learn these things along the way too, just so that we can all adapt, because I guess that's really important, especially nowadays. Yeah, and again, that's a very broad question that bears a lot for context. So yeah.
Yes, definitely. I hope ma'am has answered everybody's questions up to her, you know, to her knowledge. So now I think we can end the question and answer session here. So thanks a lot, everybody, for participating in such a fantastic event on behalf of MHLU and Bern University of Applied Sciences. It has been an honor. And I would like to thank our esteemed speaker, our faculty, staff, my students, and the MHLU members. Ultimately, I extend our heartfelt thanks to Dr. Cherry Verghese, Director of Prasanna School of Public Health, MAHE Manipal, the MAHE Press, Media, and Media Administration, and all the support we have received today. If I have not mentioned any names, but many thanks to everyone who has contributed directly or indirectly to contributing this webinar. I'm wishing you all a great day ahead. And once again, Dr. Anna, thank you so much for your time to come with us, have this webinar, and share your knowledge to our participants. Thank you so much.
Thank you for having me.